Welcome to this first series of lectures on oral medicine. This one is entitled History, Special Tests and Diagnosis. One must remember with all patients, that to treat the patient respectfully as a person and not as a mouth or a disease requiring treatment. What I mean by this is that don't hone in on the first problem that you see. Seek some guidance from the patient as to why they are there, and therefore carry out a good history. Before we go on with the lecture, we need to identify what is diagnosis and how does the clinician achieve this. This is important as this process will not only help the student or clinician in a day-to-day clinical life, no matter what type of problem the patient presents with. So the function of the diagnosis is to offer the safest and most effective treatment and therefore an indication of prognosis. Note that a clinician can only diagnose conditions known to them, therefore knowledge available to the clinician is through study, clinical experience, reading the current literature, discussion with colleagues, and access to the internet. Don't forget that your patient will also have access to the internet, and they will have checked up on their problem. But as the expert in the field, you will be able to help the patient unravel the mysteries of the internet and the good and the bad articles that are present in that. Remember, a referral to a specialist is always a possibility. If we start with the definition of diagnosis, diagnosis is the determination of the nature of a disease condition by careful investigation of its symptoms and its history. So here, basically, what this tells you is that it is the history of the problem, the medical history, the social history, and examination of the patient that is paramount in arriving at your diagnosis or a differential diagnosis. And then you may carry out special tests to eliminate some of those problems on your list. If we follow a recipe for diagnosis and you use that systematically with each and every one of your patients, then you will get into a much better habit and become a much better clinician. The menu starts with the reason for the visit, and you will only know this by asking the question from the patient. Their medical history may be written in the form of a medical questionnaire, but you may also question them in addition to this in the clinical setting, and it will include their current medications. Subjective history, or the symptoms, is a detail of the problem that the patient is presenting with and any other relevant information. Objective testing or signs is the examination that you carry out and the special test that you may ask for at the end. Once you have obtained all this data, then you will analyze it and come up with a clinical diagnosis. If at this stage further testing is needed to confirm a clinical diagnosis by the way of biopsy and or other special tests, then these may be carried out. And once the diagnosis is arrived at, we can then carry on with the plan of action, which becomes your treatment plan. A symptom is any bodily change that is perceptible to the patient, whereas a sign is any bodily change that is perceptible to the trained observer. So diagnosis will begin with the reason for the visit, and you may ask simple questions. They may be open-ended. Tell me about your pain. Or a closed question such as, what does the pain feel like? Or a leading question, does the pain feel like an electric shock? Depending on the way you ask the question, or you will ask the question in a way to gain the information that you actually require. So, why have you come to see me today? Or what is the problem? Or what is troubling you? Are reasonably accurate questions that you may ask. History of the presenting complaint, you may ask, where is the problem? When did it start? Has it got worse? Has it improved, or has it stayed the same? Is there, if it's to do with pain, is there pain associated? The pain history is the most important thing in the diagnosis of especially a chronic pain condition. In a pain questionnaire, you may ask about the type of pain, which would include is it an aching pain or a dull pain, throbbing pain, shooting pain, electric shock, and write down in the patient's own words which type of pain they indicate. The severity is important. Is it a mild pain, which is managed by analgesics, or a moderate, unresponsive to analgesics, or severe, which disturbs sleep? You can use questions like a scale, on a scale of 0 to 10, where 0 is no pain and 10 is the most severe pain you can have. Where would you put your pain at? And this would help, especially with chronic pain, to monitor your progress of management. Duration, time on onset, or duration of attacks. When did it start? How long does the pain last? How often do they occur? Is it continuous or paroxysmal? So, is it episodic, or is the pain there all the time? Is there anything that initiates the pain, or is there anything that makes the pain worse, or is there anything that relieves the pain? Is it well localized, or is it poorly localized? Is there referred pain? The following slides will indicate some notes on pulpal pain and periodontal pain. You will be getting this in other areas of your study, so I won't labour on it too much, and we will just skip along them reasonably quickly. Enough to say that hot and cold, or temperature, pain to temperature, often indicates a pain of dental origin. Note that pain may be of non-dental origin, and even though this is not our area as dental clinicians, be aware that sinus pain or ptealgia or pain referred from other sites may mimic dental pain or oral pain. And also, once all of these things have eliminated and you have chronic pain, then there may be a differential diagnosis that we may form. And the one I like to use is by Robert L. Merrill. And even though there is a lot of subcategories there, the main categories of musculoskeletal, neurovascular, neuropathic, or psychogenic. The musculoskeletal heading has under it the muscle pain conditions to do with temporomandibular disorders, problems with joint mechanics, the likes of clicking, locking, or pain associated with mouth opening, arthritis conditions such as osteoarthritis, rheumatoid arthritis. Even though these are very rare in the temporomandibular joint, they can occur. Under the neurovascular heading, there are conditions such as migraines, which can cause headaches. Headaches are also associated with some of the temporomandibular disorders. And also under the neurovascular heading is autonomic cephalgias, and especially cluster headache and paroxysmal hemicrania. These are two conditions that are diagnosed mainly on the history, where the patient may indicate a unilateral pain, like a shooting pain up the side of the face, going from the mouth up to the eye. They may indicate that the pain occurs at the same time every day, often early in the morning. It wakes them with watering eyes on that side of the pain, and also a blocked nose or runny nose. And the distinction between cluster headache and paroxysmal hemicrania is that the pain lasts longer in one instance than the other, and the treatment is by medication, but the medications for the two different conditions are different. Neuropathic pain, neuropathic meaning pathology of the nerves, can often be a bugbear for dental clinicians, especially that of the peripheral neuropathic pain, where the pain may mimic a dental pain, and this is where a patient may present to a clinician and can be very demanding and pointing to a tooth saying, "I've got severe pain, you need to do something, please take this tooth out." And on many occasions I have had referred patients who have had these teeth out, but the pain is still remaining. So be very careful of this sort of situation, and as a clinician you should always make sure that if you cannot find anything clinically wrong with a tooth, that you do not do anything to that tooth until you either review that tooth or get a second opinion. Remember, referral to a specialist is always an option. Under this category are the neuralgias, and especially trigeminal neuralgia, which often is a combination of peripheral and central neuropathic pain, and you will learn more about this particular pain condition later on. Psychogenic pain, mainly to do with somatization disorders and psychotic disorders, which from a dental clinician point of view is rare and usually involve the treatment alongside a psychiatrist. So the medical history will, with the medical history you need to, on a regular basis, review and update the written medical questionnaire, check for the medications, the current medications the patient is on, look for allergies, and written consultation with the physician may be required. And the ABCs of what is required is written on the slide. Medical history may reveal the need for possible antibiotic prophylaxis before treatment. It may indicate the presence of medical conditions that may require caution and or extra measures, such as diabetes, pregnancy, bleeding disorders. Presence of medications that may be causative or may interact with treatment, especially prescriptions. Presence of any high-risk transmissible conditions, such as HIV or hepatitis B and C. Presence of any allergies, and here one must be reminded of latex allergy. It is important that in your clinic that you have non-latex alternative gloves, as you can see in this picture, otherwise you can create this kind of rash for a patient who is allergic. Subjective history may give rise to a provisional diagnosis. It may also determine the urgency for treatment, and confirmed by the subjective history is confirmed by your examination and special tests. There's an old saying, listen to the patient, he's telling you the diagnosis. And this I have found to be true on a number of occasions in my clinical career. And I can't indicate that more for you as a clinician to make sure that you listen to the patient. So the history of objectives is, in the summary, is to establish the rapport with the patient, because this is even more important when you're dealing with chronic patients with chronic problems, because there's going to be a long-term management plan. So that rapport will help you with your management plan. it helps you to also gather information to arrive at a provisional diagnosis. And it also gives you an understanding of the patient's wishes and expectations, which is very important. Examination, in terms of a visual examination, use of radiographs, percussion tests, palpation, mobility, thermal tests, and intraorally even electrical pulp tests, periodontal probing, selective anesthesia, test cavity for transillumination, and review of the occlusion. The visual examination will begin with the extraoral examination. Look for, and this begins as the patient walks in to your surgery, into your clinic, and look at the way they walk. Are there any weaknesses in their body? Look for any facial asymmetry. Look for any swelling, extraoral sinus tracts. Palpate the TMJs, opening and closing, and sideways movement. Check for lymph node and salivary glands. The intraoral palpation or bimanual palpation of submandibular and sublingual glands, and manual palpation of parotid glands. Occasionally cranial nerve function may need to be reviewed. Here in this case, the picture on the left shows the patient in its normal state, and the picture on the right shows swellings in the angles of the mandible and the parotid region, bilateral swelling, indicating mumps. But other conditions such as sialosis, which occurs mainly in women, you can get similar hamster cheek type swelling, but the two patients would present with different symptoms. So the mumps patient would have pain and firmness, whereas the sialosis patient will not indicate any pain. Extraoral swelling here on the left is associated with an infected tube, as seen by the periapical radiograph. Visual examination, extraoral sinus tracts may be associated with a necrotic tooth. As you can see, when you look in the test cavity or the cavity, there is a necrotic pulp, confirmed with periapical radiograph. Visual examination intraorally also, you would be looking at whether the patient is dentate or edentulous, condition of any teeth that are present, presence of any dentures and their adequacy. Soft tissue lesions, you would be looking at for presence of swelling, and again write down the colour, size and texture of the swelling, presence of any fluctuance, redness, presence of any sinus tracts. Hard tissues, which you need to eliminate the presence of any or absence of any caries, large or defective restorations, discoloured or chipped teeth. So in this photograph of a person's mouth, showing the lips on the periphery and the gingiva, which appear to be very pink and healthy with stippling. The teeth also appear to be very normal, apart from the 2-1 and the 2-2, which are discoloured. Again, they may not create any other symptoms apart from the discoloration. You would perhaps need to palpate these teeth, take a periapical radiograph, and see if there's any other symptoms or pathology associated. Otherwise, from a clinical point of view, the only problem may be for the patient of the teeth being discoloured. In this case, a patient with dry mouth, a patient with dry mouth may have cobblestone appearance of the tongue. In this case, not so obvious, and often if there's hyposalivation, lack of saliva, they will be more prone to caries, and the type of caries that you tend to get in these people are cervical caries mainly. In this patient, there's also presence of abnormal tooth wear or bruxism, which may be noted. With swelling, you might look at the site, size, texture, tenderness to palpation, fixation to underlying structures, nodes palpable. In this situation, we've got two clinical photographs, both showing palatal swelling. There's erythema on both sides, and from a clinical point of view, you may want to, for your own benefit, think about the differential diagnosis for the two cases. And some of you may suggest infection, abscess, tumour, or other chronic irritation as some of the differential diagnoses. But just looking at the problem, you can only come up with a differential diagnosis. You need to do further testing to find out exactly what's going on. So the one on the left is a palatal abscess, the one on the right is a salivary gland tumour. Tumours are usually painless enlargement of the gland. It could be primary or secondary, it could be from another site, malignant or benign. Malignant tend to grow very quick and are often painful. Benign are very common in minor salivary gland. So obviously this large swelling on the side of this unfortunate woman, most likely to be benign, and probably would have been there for a long time, slow growing. Possible diagnosis associated with the pulp, again, I'm not going to labour on these points because you will get an indication of this in other subjects, but I have included this in the lecture just for your own benefit and completeness. So we will quickly go through these. As with periodical diagnosis, again, you will be quite familiar with these through your conservative general dentistry lectures. So if we then move along to special tests, by the time you arrive at a situation where you may be ready to order some special tests, you should have a list of differential diagnoses. And if you have followed your recipe, that list of differential diagnoses would have been quite large at the start of your appointment and would be slowly getting smaller and smaller, and by the time you reach special test stage, you should only have a handful, 1, 2 or 3 conditions that you are wanting to eliminate. And then you use special test as an adjunct to the history and examination, and you use that for confirmation of your diagnosis. And these may be in terms of blood tests, which tell you and give you an indication of the general health of the patient, presence of any deficiencies, autoimmune problems, liver function. They may have a direct association with the oral problem the patient is having, or have a bearing on how you're managing this going to proceed. And some of the tests may include imaging radiographs, and OPG, orthopantograph, is a good radiograph to give you an overview of the dental structures and the maxillomandible, as well as an outline of the sinuses, maxillary sinuses, and the TMJs. If you want a closer examination of the TMJs, then temporomandibular joints, you might ask for temporomandibular joint views. And these ones are mainly for the hard tissues. A CT scan may also allow visualization of 2 to 10 millimeter sections of the body in 2 dimensions. They're good for mainly hard tissues again. An MRI is a safe, non-invasive technique and allows 3D imaging of internal organs, and these are often good for soft tissue review. Ultrasound uses high frequency sound waves, which bounce echoes off soft tissues, determine if something is solid or fluid. It's again good for the soft tissue. You can also use radionuclide examination of bone or salivary gland or thyroid and lymph nodes, where a nucleotide is injected with a label to diphosphonate, and then you look at that under a gamma camera. Biopsies may be carried out, an incisional biopsy where you take a sample of part of the lesion that you want to diagnose, as well as some normal tissue. An excisional biopsy is carried out where if you have a lesion that is small enough that you might as well take the whole lesion. Fine needle aspiration is carried out sometimes where you're looking at a fluid-filled lesion, where you may aspirate some of the contents and then look at that under the microscope. A core biopsy will give a core of a mass of tissue that you're trying to examine. So as a result of the evaluation of information and the results obtained in the history and examination of special tests, you arrive at a diagnosis. And this diagnosis forms the basis for formulating the management regime and considering prognosis. Thank you.